Have you ever heard of amyloidosis? If not, you're not alone. It's a rare, often underrecognized disease, but one with growing importance in clinical practice. Now let's take a closer look at one of the most impactful and underrecognized forms of amyloidosis, amyloid cardiomyopathy, or ACM. ACM, also referred to as cardiac amyloidosis, is an increasingly acknowledged contributor to heart failure. It occurs due to the extracellular deposition of misfolded proteins, most commonly immunoglobulin light chains, AL, or transthyretin, TTR, proteins within the cardiac tissue. In cardiac amyloidosis, amyloid fibrils infiltrate the myocardium, the muscular layer of the heart wall, leading to a condition called restrictive cardiomyopathy, where the heart becomes stiff and unable to fill properly with blood. The result? Diastolic dysfunction, which eventually progresses to full-blown heart failure. In addition, the conduction system of the heart can be affected, increasing the risk of arrhythmias, especially in older adults. Let's explore the three primary types of amyloidosis that affect the heart, starting with the most prevalent. Transthyretin amyloidosis, or ATTR. ATTR amyloidosis is caused by the misfolding of a protein called transthyretin, or TTR, which aggregates and deposits as amyloid in various tissues and organs. TTR is mostly made in the liver. Once released into the bloodstream, its role is to transport vitamin A and the hormone thyroxine around the body. In order to do so, 4 individual TTR proteins must be attached to each other to form a 4-unit complex before it can carry vitamin A or thyroxine. In ATTR amyloidosis, the 4-unit complex is made up in the normal way, but is unstable and prone to breaking up. In some cases, this is a result of inheriting a mutation in the TTR gene, which gives rise to TTR proteins that don't fit well together. This is known as hereditary ATTR amyloidosis. In other cases, the individual TTR proteins become altered as we age, but what causes this to happen isn't known. This type is generally referred to as wild-type ATTR amyloidosis. Once apart, the TTR proteins have a tendency to misfold and aggregate to form fibrils which deposit as amyloid. TTR amyloid deposits are most commonly found in the heart, where they cause cardiomyopathy, and in the nervous system where they cause neuropathy. Deposits can also be found in the digestive system and kidneys. As the amyloid builds up, it starts to disrupt the function of affected organs and cause symptoms. The second type is systemic light chain amyloidosis, or AL. Proteins are important molecules involved in almost every structure and function within our cells. They are made up of chains of smaller units called amino acids, which fold themselves into 3-dimensional structures. Folding allows the protein to work properly and interact with other molecules. In amyloidosis, proteins are made in the normal way, but when they are released from the cell, they open up again. These abnormally folded proteins collect together in long chains of fibrils. The deposits they form are called amyloid. Amyloid fibrils are difficult to break down and as they accumulate start to cause damage. Eventually, the buildup of amyloid fibrils stops the affected tissue from working properly. Amyloidosis is caused by a bone marrow disorder. The bone marrow produces blood cells, including plasma cells, a type of white blood cell that forms part of the immune system. Plasma cells make antibodies to help fight infection. Each antibody is made up of 4 protein chains, 2 heavy chains and 2 light chains which attach to each other to form the complete antibody. In amyloidosis, the abnormal protein that builds up and causes problems is the antibody light chain, hence the name amyloidosis. Instead of attaching to heavy chains, the abnormal light chains open up and bind to other abnormal light chains to form amyloid fibrils. These gradually build up over time. Amyloid light chain fibrils can occur almost anywhere in the body, But the organs most commonly affected include the kidneys, the heart, liver, spleen, nerves, and the digestive system. Finally, we have AA amyloidosis, caused by serum amyloid A protein fragments and linked to chronic inflammation. It rarely causes cardiac involvement. However, isolated atrial amyloidosis, formed by atrial natriuretic peptide, has been associated with atrial fibrillation and is present in over 90% of nonagenarians. So there you have it, the three major forms of amyloidosis that can impact the heart. 1. ATTR, hereditary or wild type. 2. AL, from misfolded light chains. 3. AA, rare inflammation related. Each type has its own pathogenesis, diagnostic challenges, and distinct clinical course. In our following modules, we'll walk through the diagnostic algorithm and emerging treatments available for these life-altering conditions. So why is this disease still so difficult to diagnose? One major reason is that the symptoms are non-specific, like fatigue, weight loss, swelling, or neuropathy. These can easily be misattributed to more common conditions such as heart failure, chronic kidney disease, or even aging. This leads to significant delays in diagnosis, sometimes by years. But there's hope. With growing awareness and continuous innovation in diagnostic techniques, healthcare professionals are beginning to better recognize the signs of amyloidosis, especially ATTR amyloidosis, a subtype that has gained increasing visibility in recent years. A major advancement in recent years has come from cardiac imaging. This has been particularly valuable in diagnosing cardiac amyloidosis, especially in patients with transthyretin amyloid cardiomyopathy, ATTR-CM. Thanks to improved imaging modalities like cardiac MRI and nuclear scintigraphy, clinicians can now better detect myocardial amyloid deposits, which were often missed in the past. In our next lesson, we'll take a focused dive into hereditary ATTR amyloidosis, a genetically driven form of the disease. You'll learn about TTR gene mutations, inheritance patterns, clinical phenotypes, and the profound impact of genetic testing on early diagnosis and family care. Whether you're a clinician, researcher, or healthcare learner, understanding the hereditary form is essential to addressing disparities and advancing patient-centered care.